persons, senior doctors and friends, at the outset my sincere thanks to Dr. GVK sir for once again making me a part of 3D Con. So my talk is choosing the right drug with respect to chronic kidney disease. So let me start with the chronic kidney disease definition. So abnormalities of the kidney with respect to the structure and function which is present for less than 3 months with implications with various criteria, with albuminuria, with structural abnormalities, with microalbuminuria and EGFR less than 30 to 60. So these are the things. So among which when proteinuria is sometimes absent in patients with diabetes, and hence it is defined as diabetes kidney disease. So diabetes kidney disease is a clinical syndrome characterized by various things: persistent albuminuria, frequently associated with diabetic nephropathy, and progressive decline in the glomerular filtration rate. So with this definition, so diabetes kidney disease, we all know it's a leading cause for the end stage renal disease, accounting for approximately 50% of the cases within the developed world. And also the cost for care with diabetic kidney disease are extraordinarily high. And increased albuminuria and decreased GFR are each independently and adaptively associated with an increase in all-cause and cardiovascular mortality. So the absence of albuminuria in persons with reduced EGFR and diabetes raises the possibilities of non-diabetic kidney disease. So what do we know about this chronic kidney disease with respect to India? So this report from the Indian Chronic Kidney Disease Registry, they say diabetic nephropathy is the leading cause of chronic kidney disease, and diabetes along with hypertension are the most common causes of diabetic kidney disease. So both the diabetes and kidney disease affects millions of adults across the world and continue to affect more in the years to come. So nearly 422 million people of adults are living with diabetes, out of which 30 to 40% of these patients who have diabetic kidney disease do not receive or little pre-end stage renal disease nephrology care. So what is the prevalence? So I just told it's more than 8 to 16% worldwide and 17% in India, and they have chronic kidney disease. They require treatment will increase more than 5 million by the year 2030. So chronic kidney disease incidence is estimated at 800 million per population in India, and in India diabetes is the most common cause of chronic kidney disease. So with respect to diagnosis, there has been a shift in the change the things. If you just see, whereas there has been a stepwise progression to end stage renal disease in those days, but now even from a normal thing they can just lead to an end stage renal disease. So this change has paved a way in the management of chronic kidney disease. So we know the cost, how much cost everything, the cost of hemodialysis, the cost of erythropoietin, how much, and the cost of transplant and post-transplant medicines. With this huge financial background, so diabetes and concomitant chronic kidney disease, they accelerate the cardiovascular disease and they have a cyclic representation. So kidney disease powerfully predicts increased mortality in people with diabetes. So without kidney disease, diabetes is not associated with a large increase in the mortality risk, and the coexistence of kidney disease and diabetes is associated with greater mortality rate. So this is the pathogenesis of kidney disease with respect to diabetes. I am not going to go into the things. So the hemodynamic and metabolic factors, they have a central role for chronic hyperglycemia, and they have pivotal roles in the pathophysiology. So the next slide, these are the factors which are implicated in the pathogenesis of hyperfiltration in diabetes. There has been found an increased glomerular pressure which has been attributed due to inflammation and fibrosis. So with this background of things, the prevalence and things, we will just have a bird's eye view on the management of chronic kidney disease and what alterations has to be done. So chronic kidney disease is associated to multiple alterations in the carbohydrate and insulin metabolism that should be taken into account when treating a diabetic patients with altered renal function. So chronic kidney disease eventually leads to insulin resistance and decreased insulin degradation. So if you just see the insulin use in chronic kidney disease in stage 4 and stage 5, more than 50% of the diabetes patients have been using insulin therapy. So diabetes management differs in chronic kidney disease. Why? Kidney metabolizes 25% of the circulating insulin and kidney contributes 20% of gluconeogenesis. So most OHAs are excreted by the kidney, and exogenous insulin, the T half, is prolonged when the eGFR is less than 60. So the kidney contributes to glucose homeostasis through the process of gluconeogenesis, glucose filtration, glucose reabsorption, and glucose consumption. So each of these processes can be altered in patients with type 2 diabetes. So the role of kidney in the metabolism of insulin. So in non-diabetic individuals, 40 to 50% of the insulin which has been excreted is extracted during its first passage. So of the total renal insulin clearance, approximately 60% occurs by glomerular filtration and 40% by extraction from the peritubular things. So almost 50% of the endogenous insulin is metabolized in the liver. So these are the things. So in patients with advanced renal failure, the basal plasma levels of insulin are elevated, the renal clearance of C-peptide is greater, and during the early phase of renal insufficiency, there has been found to impaired renal insulin clearance, which is due to reduced renal blood flow. And as the renal function declines, the effect of renal blood flow is aggravated by a decline of tissue extraction of insulin. So insulin resistance and insulin secretion, the skeletal muscle, we all know it's a primary site of insulin resistance, and it has been the accumulation of uremic toxins and excess of parathyroid hormone. And insulin secretions seems to be blunted with respect to metabolic acidosis and parathyroid hormone excess. So this is a thing about the insulin sensitivity with respect to the chronic kidney disease and the etiology of the insulin resistance in chronic kidney disease. I am not going into detail. Inflammation has been found to be the triggering factor of insulin resistance, and the chronic kidney progress with respect to the insulin resistance. So a few things about the insulin requirements. So the insulin requirements, it shows a biphasic course in patients with diabetes and renal disease. In the beginning, glucose control deteriorates because of insulin resistance. Therefore, more insulin is needed to achieve the glycemic targets. But in case of advanced renal failure with creatinine clearance below 50 ml, the need for insulin is lower, or even cessation of insulin may be necessary. So insulin requirements is decreased because of less calorie intake. With the institution of hemodialysis, the insulin changes has to be taken because of insulin sensitivity and liver metabolism improvement. So a special care about hypoglycemia has to be taken because of decreased calorie intake and reduced renal gluconeogenesis. So glycemic control in patients with diabetes, HbA1c seems to be the most accurate method due to the reduced red blood cells, recent transfusion and other things. So what are the targets? So ADA recommends patients with type 1 diabetes at least 3 times a day, fasting glucose less than 140, 1 hour postprandial less than 200, and HbA1c 6 to 7% in type 1 diabetes and 7 to 8% in type 2 diabetes that are on hemodialysis are considered acceptable. So these are the targets with respect to diabetes kidney disease. So the guidelines on use of OADs and insulin, the risk of mortality in patients with type 2 diabetes, and it has been found that A1C plays a pivotal role. So higher HbA1c levels are associated with in the stage of chronic kidney disease with less than eGFR less than 60 are associated with worst outcomes. So there has been a strong relationship between the HbA1c and the outcome of end-stage renal disease. So this is the clinical evidence or the evidence-based information as per the ACCORD trial. A U-shaped relationship between the A1C and mortality has been demonstrated. So these are the various dose adjustments which are needed for the OADs. So if you just see the metformin, we can use up to a EGFR of less than 30 and the creatinine clearance of 1.73. And with respect to the sulfonylureas, so we have been found that no dose adjustment is needed with glipizide, and initiate glimepiride at a lower dose, and glyburide better to avoid. With respect to the glinides, the meglitinide, so initiate at a lower dose and we can just use it up to an EGFR of less than 30. So moving on to the next thing, the thiazolidones, no dose adjustment is required, but it is not used due to the increased weight gain. And the alpha glucosidase inhibitor, you can avoid when the EGFR is less than 30. And with respect to GLP-1 receptor agonist, not recommended in EGFR less than 30, and the liraglutide is not recommended even with EGFR less than 60, and albiglutide, no dose adjustment is required. So these are the various gliptins, we have been using it. So no dose requirement is required with respect to linagliptin, otherwise 100 milligram daily for sitagliptin if the EGFR is greater than 60. When the EGFR comes down to 30 to 60, reduce to 50 milligram, and if the EGFR is less than 30, even 25 milligram daily. With respect to the alogliptin and saxagliptin, even it can be used up to an EGFR of less than 50. So with respect to the other drugs, the class of SGLT2 inhibitors. So only canagliflozin, no dose is required adjustment. Only avoid this canagliflozin when the EGFR is less than 45, and dapagliflozin can be used up to 45. Yes, sir. So these are the various individual class of things. So metformin may be safely used in patients with EGFR with EGFR less than 30, or the urine creatinine ratio up to 1.73. So up to EGFR less than 60, no contraindication. When the EGFR comes down to 45, continue the use with increased monitoring of renal function, and it can be safely used up to EGFR less than 30, and less than 30 better to stop metformin. So sulfonylureas, the safer drug is glipizide, no dose adjustment is required. Glimepiride, we can start safely with a lower dose of 1 milligram and slowly we can titrate. But when in the stage 4 to 5, better to avoid sulfonylureas due to the increased risk of hypoglycemia. So these are the aspects with respect to glinides which I told before. Only thing, these things with respect to the things. So I'll just move on to the last part of things, the insulin aspect, the prandial insulins. So with respect to insulins, there had been studied up to EGFR less than 50, and the aspart, it can be safely used in all stages of chronic kidney disease, and lispro, it also proven safely in all stages of renal disease including end stage renal disease, and glulisin, it has been used safely up to EGFR less than 45. So insulin requirement of the prandial insulins in various kidney stages of kidney disease, it has been shown that it can be safely used with respect to the EGFRs. So the basal insulins, the glargine can be safely used in all stages of renal disease, and detimir also it can be safely used, whereas the degludec, it can be even used in case of end stage renal disease. So the basal insulin used in chronic kidney disease. So they have found no significant difference with respect to the PK study between the normal and variable degrees of renal impairment with respect to insulin detimir and glargine. So what about the premix insulin? So the biphasic insulin aspart, there has been evidence that they can be safely used, and the co-formulation, only individual evidence has been available with respect to aspart and degludec, no studies with respect to the co-formulation. So these are the common insulin titration guidelines with respect to the EGFR. So according to the EGFR, insulin dose reduction is recommended with respect to the chronic kidney disease. So the recommendations, they say when the EGFR is greater than 60, no reduction. When it come down to 40 to 30, 25% reduction has to be taken. When the EGFR comes down to 15, less than 50% of the dose has to be reduced. So these are the group 2 recommendations according to the body weight, and in the EGFR is greater than 60, we have to start with 1 gram per body weight with respect to type 1 diabetes, and type 2 diabetes just 0.5 units per kilogram body weight. And when the EGFR is less than 30, that is 60 to 45, we have to start with 0.75 units with respect to type 1 and 0.3 to 0.4 units with respect to type 2. And when the EGFR comes down to less than 15, we have to start with 0.5 units per kilogram body weight in type 1 diabetes and 0.25 units per kilogram body weight in type 2 diabetes. So with this, I conclude that diabetes kidney disease has emerged as a major aftermath of the worldwide diabetes pandemic, and diabetes prevention must remain at the cornerstone of reducing the diabetes kidney disease. Identification depends upon screening for increased albuminuria and low EGFR. Prevention of cardiovascular disease, a major cause of death in diabetes kidney disease, centers upon management of the LDL cholesterol and the blood pressure. And more than 50% of the persons with diabetes having chronic kidney disease are treated with insulin. So initiate insulin at smaller doses with strict monitoring of patients with diabetes having chronic kidney disease. Newer insulin analogs may be preferred as their pharmacokinetics are unaltered in case of chronic kidney disease, and doses needs to be titrated as per requirements to reduce the risk of hypoglycemia. So thank you for the patient hearing.